Well, good morning to everyone. My name is Jean Branscombe, and I am the current CAO of Big Sky Care Connect. And welcome to our panel on leading care connections, taking charge to improve healthcare. We have a remarkable panel of experts today to really dig down into the value of healthcare and to give a perspective from what a health information exchange can do for Montana, can do for your own local community, and can do for your own particular place of employment, your facility, and particularly for our patients. Our panel today, just as a rundown, and we'll do some self-introductions in just a few minutes, includes Sean Alfreds. He's with Maine Health InfoNet. Dr. David Mark with the Bighorn Valley Health Center. Jason Spring with Kalispell Regional Hospital Healthcare, Barron Thompson, the Innovative Care Partners, and Dr. Randy Thompson, a physician from Billings Clinic. To start us out with, I want to give a little bit of background on the Health Information Exchange. And I gave some background this morning during the opening and just want to add on to that. If you want to go to the next slide. So just as a bit of background, and for those that may not have been able to join the opening remarks today, I just want to kind of reflect real quickly in regards to, how we came about to having Big Sky Care Connect become the premier health information exchange for the state of Montana. And that journey has been one that's happened over a few years just because of the thoughtfulness that we wanted to have in regards to putting the right pieces together at the right time for the right reasons for Montana. So the conversation started back in 2016. It was generated by an advisory council that Governor Steve Bullock had put together in regards to transforming the healthcare delivery system in Montana. Based on the work that was done and the introductory conference that was done and held in 2016, we dove into doing a feasibility study in 2017. Montana had tried a health information exchange in the past, and there were some concerns whether or not it was really feasible for our state to dive back into that, and if this was the right time to do that, and could it be sustainable? We spent a year really diving deep into that feasibility and sustainability question, and at the end of 2017, it was clear that it was indeed feasible to do that and very much sustainable. And actually, it showed a strong interest in having that conversation again. And so with that in hand, we formed an organizing board. And in 2018, we formed Big Sky Care Connect. In 2018, it was a year of formation for us. So we did all those typical things of doing bylaws, articles of incorporation, but we also started doing a business plan for Montana, and we formed a governance board. And we decided in the formation of this organization that it would be a nonprofit, neutral entity that could convene the kind of providers and payers and employers and patients for the conversations that were needed to really make this be a successful, innovative project for the state of Montana. So in 2019, we completed that business plan. We secured funding through the state legislative branch, also worked with Medicaid to secure money through the through the high-tech funds. And with that completed business plan, we began the process of securing a technology vendor and also doing contracts with experts who have been in the process of forming HIEs across the land. We were successful in doing that, and in March 2020, not that long ago, we signed a contract with InterSystems, a global leader in this space in their technology infrastructure. With that in hand, we have gone through other processes to decide what we really needed to have as part of our technology infrastructure. And the slide in front of you shows the core services that will be provided through our platform, which will go live by the end of this year. So that will include a comprehensive patient record, a provider portal, medication history services, a HIE health exchange, so you'll have access to Veterans Affairs, Department of Defense, other health information exchanges, Commonwealth, and other pipelines to other data houses across the nation. It'll also include significant patient event notifications. For example, if you're a primary care physician and your patient enters the emergency department, we'll have a notification that alert you to that happening so that you can follow up when you get back into the office on Monday. And we'll also are providing direct secure messaging. Next slide, please. So building the HIE house has taken thought, it has taken time, but we're doing that in a very methodical way to make sure that when we have all the pieces together, they're the right pieces and they're the pieces that are most relevant to our providers and payers and will lead to the end game, which is better patient outcomes across Montana. So when you take a look at the health information exchange, and you'll see I have the opportunity to see a demonstration of what it will actually look like, is that at the very top in the green, you'll see that people are going to be able to access our health information exchange through a single sign-on or a direct query or a provider portal. And they're going to be able to gain access into that comprehensive patient record through some of those indications that I had just mentioned before. Of course, it's going to be secure. We're going to follow all the HIPAA regulations, and there'll be a maintenance and watching who's accessing records through audit logs. So right now we have medication history coming your direction. We'll also be working in future services to do immunization registry, connecting with the cancer registry, the advanced directives registry. We'll be having connections to electronic labs, to our labs like Quest and LabCorp and the state lab, so that there can be some reporting and exchange of information there. And we also are going to be available to help with syndromic surveillance as well. Currently out in the field is an RFP to add a data analytics and quality metrics to our platform. And we'll soon be issuing requests for proposals for an image exchange and care management. So we're well on our way to having a health information exchange that's going to provide the services you want and that will help you and be a tool that you can use to achieve the triple aim. And that brings us to our panel today. And we want to hear from our panel in regards to what the health information exchange means or could mean to their own facility, and to also hear from other states in regards to what the health information exchange build has been for them and the value their state has found with the health information exchange. So with that, I'm delighted to introduce Jason Spring. Jason.
Thanks, Jean. And thanks for walking us through that. It's helpful to remember the history of how we got here. It seems like, 4 or 5 years ago, this was a long stretch, and some of us were skeptics, and I'll talk a little bit about that. I'm Jason Spring. I'm the Chief Strategy Officer for Kalispell Regional Healthcare, and I'm glad to be here with you this morning to discuss Big Sky Care Connect. I joined Kalispell Regional about 4.5 years ago. I previously was the CEO of North Valley Hospital in Whitefish, and have been active in this statewide HIE conversation for a few years now, and we'll share a little bit about why, how that's involved, and the solutions that we're already finding by having the HIE infrastructure coming online. So a little history with North Valley and Kalispell Regional is we've been engaged for about 15 years with the Health Information Exchange of Montana, which was an early HIE effort. This was set up as a 501c3 corporation with Northwest Montana members, including Kalispell Regional, Critical Access Hospitals, FQHCs, and the University of Montana. And the effort was to create an HIE that didn't actually happen. We ended up becoming a fiber company that now owns and operates some 500 miles of fiber in Northwest Montana. Fiber goes from Missoula up to Eureka, up 93 to Eureka, over to Libby, around to Conrad, along Glacier National Park, in a partnership with BNSF, across to Shelby, down to Conrad, and then comes back around to Missoula. And I won't spend a lot of time on that particular project, but it was that project of trying to start an HIE that led us to this fiber company, and we learned some things along the way. And one of those is that having an effective HIE is really hard work. And for the Health Information Exchange of Montana, we never succeeded. However, as I mentioned, we did end up with a fiber company that's pretty invaluable to us to connect healthcare providers and healthcare education about putting forth that effort. So taking the lead on that and the risk in that project didn't turn out as planned, but it did lead to something successful and meaningful. And I think we'll see the same theme with Big Sky Care Connect when we look back 10 to 15 years. That list of core services and future services that Jean just walked through are probably just the tip of the iceberg of what we will be able to do as technology improves and big data evolves going forward. And so we're happy to be joining that. And it's that previous experience with the Health Information Exchange of Montana that compelled us to be engaged in the early stages of Big Sky Care Connect. We wanted to make sure we had some role in shaping the concept versus waiting for others to fully develop it and then wish we would have participated. But to be honest, I was an early skeptic on the business model and the need for an HIE for KRH. Early on, we believed that 95% of our patient population would come from markets where we had installed KRH's Meditech platform, and that the value to KRH to support an expensive HIE really wouldn't translate into a good business decision. But we didn't have competing emergency departments across the street where patients bounce back and forth. We're pretty isolated up here in Northwest Montana. And most days we kind of like that. But I stated publicly at a number of the early HIE stakeholder meetings that the business model was not likely right for us. And then somehow got asked to chair, I think the title of it was the business committee then. And I remember telling Jean I was not the best person to chair the committee since I was the biggest skeptic on the committee. She asked me to do it anyway, and as that committee developed and reported to I think what was called the governance committee at the time, the business model became something that I believe really created a real value proposition for healthcare providers in Montana. And every detail of that value proposition is still not probably ironed out. I believe that if we didn't start creating that model, we would be getting further away from the solution versus leading to the solution. I'm confident in the long term that this will create the ability for providers to better serve patients through real-time data for issues like care coordination, centers of excellence, value-based payment models, and effectively better understanding the health of a population, and more importantly, how to improve the health of a population. All of the elements may not be fully developed, but certainly the ideal state will be harder to achieve without shared data across populations versus data being held in siloed environments across the state. And Kalispell Regional can already see a couple of real scenarios that make it valuable to us that were not evident in those early conversations. First, as Montana Children's continues to develop referral patterns across the state for specialty pediatrics, it will allow for faster treatment when a patient presents in an emergency and for considerably better care coordination when they return home. This pediatric population was not anticipated in our early discussions about the 5% of the patients that would not be in the KRH Meditech platform. The HIE will be extremely helpful for coordinating care with these complex pediatric patients. A second example is as we onboard several new Meditech facilities, whether through a merger acquisition or just a community partnership, it allows us to use data stored in the HIE for clinical care from those legacy systems versus continuing clinical access to legacy systems for years to ensure data is available, or trying to migrate that data into Meditech. And as you saw, it's a single sign-on to the HIE, which will allow clinicians to be able to access that data quickly. This has a clear impact on patient care and efficiency for us that would require an additional solution, if not for Big Sky Care Connect. And third, I learned about this one yesterday, and nobody should ask me very many questions about it because I got it from HIT and I'm not very deep into that space. But the third is that CMS has new interoperability requirements for ADT triggers in 2021 that our IT team believes can be accomplished through the HIE versus CareH having to meet those through our own system. And that certainly was anticipated. So these are 3 real case studies that will drive better access to patient data because of Big Sky Care Connect. We are now one of the early adopters at CareH, and because of these unanticipated advantages, we're currently implementing and expect to be connected by the end of the year. So I want to pause for a second and thank Gene and the Big Sky board members, St. Vincent's Billing Clinic, Blue Cross Blue Shield, Medicaid, all those people that stuck with this HIE project. I'm sure I'm leaving out a few who engaged and frankly endured skeptics like me and continue to push in the midst of one challenge after another in our industry, truly leading this care connection. So I look forward to hearing from the remaining speakers on the panel to share more about their hard work to develop a statewide HIE and the benefits to their patients that are up and active in other states. I appreciate you guys inviting me to participate today, and happy to respond to any questions except for the one about the ADT triggers after the rest of the panel speaks. So thanks. I'll turn it back to you, Gene.
All right. Thank you, Jason. And thank you and your organization for being an early adopter. And it's those lessons learned from your own project that you did up there and even HealthShare Montana that is making us a success today, is putting those lessons learned to work for us. If you have questions for Jason or for any of our panel members, what we're going to do is ask you to use that chat room. And I'll moderate that chat room, and we have a couple of others moderating that as well. And we'll present those as we move along in our panel discussion today. Next, I want to introduce Farron Thompson with Innovation Care Partners.
Thanks, Gene. Thanks for having me on your panel today. Always happy to help out our colleagues in healthcare, see if they can learn anything from what we've done in our organization. So I want to give everybody a little overview of our organization and real quickly so you kind of know who we are and what we do, and then talk a little bit about our health information exchange that we have. Next slide, please. So this is our high-level mission, vision, values, and really a synopsis of what we do, or the other way we spin what we do is our keys to success. Innovation Care Partners is an accountable care organization and clinical integration network. We're in Scottsdale, Arizona. We started our company back in 2012, actually probably a little bit before the term population health became popular. And we'll talk a little bit in a few other slides about our demographics and the number of patients that we serve across all the different dimensions, et cetera. But we're real serious about accountable care. Fortunately, our board, when we started this and up to this day, kind of has the attitude, if we're going to do this, let's do it right. And that means we're all in how we've built our organization. It's not a project or a department out of a health system where we have to beg and borrow for resources from the hospital. We have our own dedicated governance structure, leadership team, and we've made significant investments in technology over the years. I would venture to say probably far more so than any ACO in the country. Everybody asks us, how have we been successful, or what do we do? And the answer is the same. It boils down to 5 key things that you see on the right side of the screen. And I'm going to talk to you a little bit about the first one. The most important key to our success is how we've engaged physicians. And there's a multi-dimensional strategy for that, including technology, including under technology, giving access to more data for our clinicians, and notifications that give them value. So that's really where our health information exchange comes into play for us. Next slide, please. So we are wholly owned by 6 hospital health system here in Maricopa County. Yes, the same Maricopa County who's all over all the news reports, wait and see election results. So we're waiting with bated breath like everybody else. Honor Health is, as I mentioned, 6 hospital system. They have a fairly small employed medical group of about 300 physicians or more. Most of them are primary care physicians, have a few urgent care sites and some joint ventures in some surgery centers. We are part of the Medicare Shared Savings Program and have been since 2014. We've got about 56,000 covered lives under that program. And we are in Track 2, if anyone is familiar with ACOs. Track 2 has some downside risk, but not full downside risk. And that's what makes us an ACO. What makes us a clinical integration network is we have about 10 or 11 other payer contracts across both commercial, Medicare Advantage, and Medicaid populations. Next slide. We provide, through our network, we don't own all of these, but we have preferred partner relationships to basically provide the full spectrum of care across the whole continuum. We've got dozens of post-acute relationships where we really select carefully the post-acute providers and have joint operating committee meetings with them and really try to engage them in our mission of improving healthcare, the quality, reducing readmissions, and lowering the cost. So whether the health system owns the resources or whether we have any of our 2,000 physicians that are, most of them are independent private practice physicians across all types of specialties and primary care, or whether it's part of our post-acute network, we can really cover the continuum of care very nicely here. Next slide. We have grown. When we started in the middle of 2012, our first contract, as you might guess, was the employee health plan of the health system that we were part of, and had maybe 1,500 lives when we opened our doors. And we've grown really extremely quickly over the years, up to around 175,000 covered lives across, and you can see the distribution across all the different payer populations and all the different insurers that we have contracts with here in Arizona. Next. So let's bring it a little bit more relevant to this topic and relate it to Big Sky Care Connect. And one of our key technologies, in fact, the key technology for us when we launched our company back in 2012, universally was we got to have a health information exchange. So we went on and selected and implemented a vendor for our private health information exchange and stood that up very quickly. By 2014, we had launched our private health information exchange, and the amount of data and the functionality has only grown over time. So you can see on this slide just a few of the different end user technologies that we've invested in, but the reason that what we call innovation exchange, which is our term for our health information exchange, the reason for that being so big a box is because it is really our foundational technology that we started the company with and continues to this day to be very foundational. There's not only the portal functionality of clinicians being able to view the longitudinal patient record in it, but the underlying technology has really enabled us to be kind of our data hub. So as we consume data from any source for any purpose, or need to share data with any other source for any purpose, really the core technology that handles all that for us is our health information exchange. And so we have all kinds of connectivity and all kinds of end users that are using our health information exchange up to this day. And it has proven over the years that it really is essential, foundational, and we could not, really function well unless we had made this investment early on. We run into a lot of different ACOs out there, and I don't know how many you have up in Montana, but many years ago, we spoke to a CEO of an ACO who said, if you've seen one ACO, you've seen one ACO. And having been in the business now for almost a decade, that is absolutely true. And I'm amazed that I see ACOs that don't have a health information exchange, and wonder, how much opportunity they're missing, and how they've made decisions and get by without a proper health information exchange. It just, for us, has been so important, strategic, and foundational. Next slide. Just some key facts about our private HIE. You can see on the bottom left all the different organizations, how many of them we have that are connected into this. We had our HIE up and running well before the state of Arizona had an HIE up and running. So since the state of Arizona has added a health information exchange, we have connected into them. So we do HIE to HIE data exchange in real time today. And that gets us access to our patients that might go to other health systems in Arizona, and we can exchange that data readily with them. We've added, the toughest thing we've ever done from an HIE perspective is get EMRs, various EMR vendors to work with us in a reasonable fashion. So it's taken us a while to make some traction on one-off EMR integrations for different provider practices. As I mentioned earlier, we've got over 2,000 physicians in our network, and you saw that maybe 300 plus are with the employed medical group. So that leaves 1,600 physicians across probably over 450 independent private practices and well over 60 different EMRs that we have to deal with out there. And so, one of the things with that spread of EMRs that many would have implementing an HIE would have guessed a long time ago was, well, how can your HIE be successful if you don't have connectivity out of the gate into all those different EMRs? Well, the answer is we want to give our providers the data that they can't easily get themselves. And so the real valuable data, it comes from health systems, the hospital encounters, emergency visits, and the reference labs that are out there. And then bringing in post-acute facility data, all of that disparate data, imaging data, and putting it all in one spot is more important and has proven to be the right strategy, rather than saying little bits of information from every particular practice is the most important thing. So our biggest priority was to get the most data that's the most valuable in at first, and then now, over the past couple of years, we've been adding in a lot more independent EMR practices. The data that we have in here, you can see, is a lot of very similar to what you're going to have. One thing that we don't have is a connection to medication fill data, but I see that you're working with Dr. First on that, so congratulations. That'll be a real big thing to have that. It's critically important. What we're doing here in Arizona is trying to impress upon the state HIE that we should not have to be held hostage for medication data in our own state. And so we're taking a little bit of a wait and see to try and get our state to pass, see if they'll take up legislation to get us out of the hostage situation on that we have with the third parties. But you can see all the other data that we have in here. We do have controlled substances. We connected into that some time ago. And then we've done a lot of homegrown customizations that add tremendous incremental value to to the HIE user, including, I know you're talking about notifications. Those are really valuable. We've built those. We've added census for our providers and our care team members, and a number of other very cool enhancements that really just add more and more value to the users. And we measure our success by the usage of our system. So we measure patient searches, and we've got over 30,000 patient searches per month. Most of those are by MAs from practices, not physicians. So the top line on this graph is MAs, and then the red line that you see down there is physicians. So as you're deploying Big Sky Care Connect and trying to look for adoption success, I'd encourage you to really think about who are the users going to be, and don't make a big assumption that physicians are always the ones that are going to use this technology. Next slide. That's it. So I guess we'll talk later on some of the questions. Thank you for your time.
Well, thank you very much, Farron. I really appreciate the points that you made about engaging physicians. You know, here in Montana, that's been critically important for us, as well as engaging not only physicians, but all our healthcare providers in the conversation of what does the HIE mean to you to be relevant. Also really appreciate that even though we're working and making sure that this fits within workflows and it's not a disruption to that, but actually is a move to less clicks in our EMR environment, that there's a variety of users that benefit from the HIE. So while we're focused on those healthcare providers, there's going to be a lot more searches and look at these records by a variety of different individuals that are working in the healthcare sector. With that in mind, I'm going to turn this over to Dr. David Mark, who is going to share his thoughts as an individual who is with Bighorn Valley Health Center.
Thanks, Jean, and hello, everybody. Yeah, my role on this panel is to change the scale a little bit and to give you all the perspective from a much smaller system, taking care of folks in the frontier space in Montana. My name is David Mark. I'm trained actually as a primary care physician in MedPeds, but I'm the CEO of the Bighorn Valley Health Center. Thank you. We are a community health center, otherwise known as an FQHC, and we deliver care to about 10,000 folks who are scattered across the central and southeastern part of the state of Montana. And this map that's on this slide shows that we have sort of a lot of space between our current sites. We're geographically pretty far apart from each other. Our care model is one of, like most community health centers, we provide outpatient comprehensive primary care in an integrated manner that includes medical, behavioral health, substance use disorder treatment, dental care, and a real intentional effort to address the sort of bigger picture social determinants of health as well. So by definition, our work requires that we interact with a whole slate of community partners that include folks sort of across the whole healthcare ecosystem. Critical access hospitals, community mental health centers, Indian Health Service hospitals, the VA system, pharmacies, private dentists, running the entire gamut. And robust communication with each of those stakeholders is really pretty key to how we seek to deliver care to our patients. So originally I was gonna sort of try to spell out to you all the value proposition for a small organization in frontier Montana. But then as it happens, I figured instead I'm gonna tell you a story, because most of my time is spent in the administrative space, but occasionally I do get to practice clinical medicine. And while that most often is in the ER or in the acute care setting, I occasionally do venture back into the outpatient setting, which is really a useful way to keep tabs on sort of the experience of our clinicians, and a good way to maintain some of my primary care chops. So last week, a colleague, a friend of mine at the Indian Health Service Hospital down in Crow Agency reached out to me to provide some consultation on a patient, a 79-year-old woman with some strange, probably rheumatological symptoms. And so I don't have usually scheduled appointments. So we set up a time where we could have this clinical encounter. And to Farron's point, the MA that I was going to be working with that day did a fabulous job of reaching out to the folks at the Crow Hospital to ensure that we had appropriate data prior to this clinical encounter. Next slide, please. For those of you who haven't worked with IHS, sort of the backbone of their information exchange is this document, which is called the health summary, the adult regular health summary. And while it's nothing to look at, it's not composed in a GUI interface. It's really sort of old school, but it's really a robust document. It contains all sorts of highly relevant information, demographics, immunization records, current medical problems, medications, labs, radiology, appointments. It's really filled with information. And this particular patient's health summary was a 23-page document, which was going to be sort of sufficient for what was needed in this particular clinical encounter. I would have access to her relevant notes and data to actually have a meaningful interaction with the patient. I think you can all see where this is heading. Next slide, please. The unfortunate weakness, the chink in the armor, is that this information required a human being to print out a 23-page document and fax it to my medical assistant, who would receive it and have it ready for the visit. And as it turns out, there's a pandemic happening, and the key member of the medical records staff in Crow happened to be out on quarantine, and thus unable to take care of this vital step in the process. And so I showed up for the visit with this patient, and we didn't have any information. So while it was very pleasant, I enjoy chatting with Julia, it was a largely useless encounter because we had no data. We couldn't really offer any meaningful clinical insight into her presentation. You know, as is the case with many health center patients, physically getting to this visit, particularly with someone like me who doesn't have regularly scheduled hours, it was a challenge for her. She lives, you know, in a frontier space on a ranch, and it had to get a ride to the health center, and we couldn't do much. So she had to go home. We had to reschedule or try to find a time to reschedule. We actually chose to redraw a set of labs, and as many of you know, the labs sort of associated with rheumatologic issues can be pretty significant and expensive. And so I think that this particular case is reasonably illustrative of why the HIE is so important. Next slide, please. At the end of the day, it was a pretty frustrating experience, both for the patient, for me, for the entire clinical care team. We, you know, again, had a pleasant visit, but it was clinically pretty unhelpful. And it occurs to me, from my vantage point as an administrator, that there was significant reputational damage, both to us as an individual organization, but also to healthcare in general. The patient's confidence in the system was significantly undermined by this experience. It's obvious to see how encounters like this drive up costs. There was opportunity cost. There was cost of repeating labs. There was cost of delayed clinical diagnosis and action for this complicated patient. And importantly, from my perspective, you know, we're really keenly attuned to this notion of our clinician burnout. It is a very real issue, and only exacerbated more so by the pandemic. As an organization, we can't afford to set up conditions where recruiting and retaining highly trained clinicians is challenged by this death by 1,000 paper cuts. And so, it occurred to me, that we're going to muddle our way through with this particular patient, but I thought this was a very illustrative example of from our perspective in the trenches in the community health center space, why this Big Sky Care Connect HIE is such a valuable tool and why we are so excited to be a part of it. I happen to serve on the board of directors, so I'm a little biased, but we're also an early adopter, and we're engaging the onboarding process and finding it to be very smooth going at this point. So I look forward to our conversation, and we'll hand it back to you, Jean. Thanks.
Well, thank you, Dr. Mark, and really appreciate you giving us that real life example of how an HIE can really benefit the experience, both on the provider side and on the patient side. Certainly, physicians and providers want to do the best and provide the best quality care every single time, and those barriers are extraordinarily frustrating to those delivering the service, but also to those patients who are getting the service and really depend on all of us to do that in a quality fashion as well. With this, we're going to turn now to Sean Alfreds of Health InfoNet.
Great, thank you, Jean, and I appreciate being here. It's a great opportunity for me to be able to share what we're doing in Maine in regard to health information exchange to Big Sky Connect in your community. Our communities are not very different. We may be all the way in the east, but we also are a very rural state, state that has 95% of the population living within 15 miles of one road. And the rest of the state being as large as all the rest of the New England states combined, plus part of New York, we have some very interesting rural health issues across our state, which the HIE has been a big part in helping to support addressing some of those issues, whether it be care coordination issues or, as Dr. Mark just talked about, the challenges that physicians and clinicians have around the state getting the information they need at the point of care. Next slide, please. Health InfoNet, by the way, my name, I'm the CEO of Health InfoNet. I've been with the organization since we got started back in 2004 in various capacities, and I've been CEO for the past 3 years. Health InfoNet operates the only health information exchange in the state of Maine. We are designated in state law as the HIE for the state, and state law also talks to patient consent and the rules of opting out for general medical and opting in for mental health and HIV information. We're a 501c3 nonprofit organization similar to Big Sky Connect, and we have a community-based voluntary board of directors, which purposefully represents many communities: our provider community, our patient community, government, and businesses throughout the state. And we provide a number of services. We provide a number of the core services that Big Sky Connect is actually bringing forward. So I'm excited to see that. And I'm going to talk to you a little bit about how we've deployed those around the state, who's using them, and the impact that it's had. Next slide, please. So for us, we went live with the Health Information Exchange in Maine in 2008. So we've had about 12 years of operation. We're connected to over 820 locations across the state, all healthcare systems, all acute care hospitals, and all the state's critical access hospitals. There are 36 of them. A majority of ambulatory practices and all of the state's federally qualified health centers and community health centers. A number of behavioral health practices. Those are growing. That's a very large initiative that we've taken on, and I've got some quotes from some behavioral health practitioners I'm going to share with you all later. And also post-acute care facilities. We're actually working in close collaboration with our state right now to onboard all skilled nursing facilities in the state, and we will have all data flowing. I am knocking on wood right now by the end of the year, at least starting with a minimum ADT for those facilities as we build out broader connections across that community. We also connect to laboratories. We have 2 state reference laboratories. We have National Reference Laboratory Quest, pathology laboratories, as well as the State Environmental Health and Testing Laboratory, which is where we get our COVID-19 results. We have a statewide emergency medical services organization, which we get data from, all state-run reports from all EMS agencies, and pharmacy. You brought up pharmacy. We have a relationship with SureScripts RX Hub, where we pull in fill pharmacy information, as well as Medicaid, because our Medicaid agency does not participate. And in our state, 25% of the population receives Medicaid coverage. So there's a lot of people there and a lot of pharmacy data. So we take in all Medicaid claims data to support both our pharmacy data sets, but also the data gaps in regard to sites that we're not connected to in the HIE. We fill that in with Medicaid claims as well. Finally, we work with public health. So we support all mandated reporting in the state for syndromic surveillance, electronic laboratory reporting, and immunization reporting. And I saw Big Sky Connect. That's in the near future. That's a big deal. It's hard for a lot of organizations, especially as we get into the smaller hospital space, the FQHC space. There's these connections. These are, again, one more connection that costs dollars for EHRs to send this information using the Health Information Exchange. It's one more of the value propositions that we've been able to bring to the community, having a single pipe that supports multiple organizations. And then we've also been able to advance our data projects forward, which I'll show you some screenshots on in a bit, about on quality reporting for our public health agency. And most recently in the pandemic, we're dealing with, we serve an important data function to support our COVID-19 contact tracing, as well as our statewide data efforts. Next slide, please. So our data sources, not dissimilar to what Farron talked about in Arizona, and obviously what you're going after in Montana. You know, we seek out and we're trying to collect as much data as we possibly can. Obviously, demographics, encounter and visit history, but then where we support all organizations in connecting to us, and starting with a minimum data set of what we call ADT, or admission, discharge, and transfer. But then we work with them to bring in additional data elements wherever we possibly can. As of late, you know, as we've expanded out our efforts, social determinants of health data is starting to be included in the exchange, including housing history, including transportation information to help support transportation needs, especially, you know, for example, you know, in the federally qualified health center space, we work a lot with Medicaid, as I said, and understanding the needs of patients that are going to the federally qualified health center, seeing their primary care practitioner, the behavioral health practitioner, but also who need transport to the laboratory. The HIE is used to help facilitate appropriate handoffs. And also the relationship between the transport as well as the to the organization itself. Next slide, please. Our clinical value use cases. This is important, and you've heard this from the folks already today. But this is our core, and this is what the HIE is about, and what it stands for in the state of Maine, and what it's used for. Obviously, care planning, care coordination. Is a critical starting place. Having the right information at the right time to provide safer care, and then improvements in quality and cost outcomes through reducing duplicate testing, avoiding hospitalizations, readmissions. These are part of the core, but we actually have the data to show it. You know, when I go into a facility and talk to a non-connected facility, I typically have the data now, because we've had so much connectivity around the state, about where their patients are and what that connectivity is. When we talk to a hospital or healthcare system in our state, we see what we call their crossover, the relationship that they have with patients who have relationships with other unaffiliated organizations throughout the state. Our average is 65% in our state. And when you look at small federally qualified health centers or our smaller critical access hospitals, 95% of the patients that are being seen in those locations, we have data on from some other unaffiliated source. That really just shows the value of the Health Information Exchange just coming out of the gate, before we even talk about the clinical use cases. Next slide, please. So as I said, I've got some screenshots here because I'm a visual learner, and I think it's helpful to see what tools the HIEs bring forward. And much as Big Sky Connect is bringing forward a clinical portal, we at Health InfoNet have had a clinical portal since we got started. And this is a view of a test patient. None of this is HIPAA data, but it does show how a clinician would interact with our systems. Much like you all, we have a single sign-on to the HIE, We also can, for clinicians who don't have EHR, so for example, a behavioral health or substance use treatment provider that's operating out of a van in Portland, Maine, they can log in through a secure connection through the web itself and log in and look up patients. We also have what we call a smart notification tool set, and you can see us on the right-hand side of the screen there. You can see the different types of notifications that we have available. We add to these on a regular basis, and we change these on a regular basis. The one good thing about having all this data is that we have flexibility in making the data useful. So while we have standard what we call ADT notifications, we also have, Maine is considered the oldest state in the nation, believe it or not. We have a lot of people in skilled nursing facilities and long-term care. So there's and a lot of folks receiving home health. And so there's a strong interest in the community to be alerted when somebody's being discharged to the home. And so we've got a skilled nursing facility unit discharge you can see here. COVID-19 being the situation we're all dealing with right now, we have COVID-19 laboratory results available, notifications that are going out in real time. So these are just some examples of some of the tools that we have just tied to the clinical portal. We can also allow folks to look up their patients and make sure that their patient relationships are established very easily. And as was talked about earlier, our primary users are medical assistants, nurse practitioners, PAs, and they can go in and associate themselves with patient panels within our HIE so that they can look at also their patient panel themselves and be alerted on a panel level, not only real time, but also in summaries, daily and weekly summaries. Next slide, please. One of the things that we brought forward recently, and this gets to workflow, our role here is to try to put data in front of the clinician at the time and point of care as easily and as quickly as we can. We've brought forward what's called a Smart on Fire API application. And what you're seeing here is the view within Epic EHR. But essentially, this is an in-context application that allows the clinician not even have to go out to our clinical portal to find basic information on their patient. Essentially, this sits on the right-hand screen, as you can see there. It's got some space, but it doesn't take up the whole screen. But quick access to routine information from the HIE, and then they can go, if they want to learn more or get more information from the HIE, they can go out to the clinical portal. But this puts it within the EHR workflow, so that during the routine visits, a clinician doesn't have to leave that workflow to collect that information, or the MA, et cetera. Next slide. As we've grown over time, our data sets have grown over time, and we've started to provide a lot more services to our community. As is the case in Innovation Care Partners in Arizona, we do a lot of support for ACOs in our state. We have 5 ACOs in the state of Maine. And so with that data, we support about 475,000 unique patients around the state in doing predictive risk analysis and comprehensive reporting in a series of different types of dashboards. We also work very closely with our Medicaid agency to help Medicaid understand who's in a bed right now, what type of encounters you have. What you're seeing here in the big screenshot there, that's an ED count for our Medicaid agency. See that big dip? That was in March. That's when COVID happened. But the red represents inappropriate ED utilization. So what these tools allow is the care managers that are working for our Medicaid agency to quickly look at their entire population, but they can click into this and drill down into specific patient levels, and then they're using the HIE to coordinate their interaction with care managers at the individual ED and hospital sites to make sure that folks who are using the emergency department and appropriately are getting the right care, and also being educated. There's one interesting patient story from a small hospital in northern Maine where one of their patients was using the ED for a lot for inappropriate reasons, and the interaction between the Medicaid agency contacted them and had a conversation with the local care manager, and the local care manager in that hospital contacted this individual, and really what it turned out was this individual was coming to the ED because they were alone and wanted to have interaction with people. It wasn't a healthcare issue. It was a community issue, and that person now is a volunteer at that hospital. and they're interacting and having a very positive relationship and not using the ED. That's just, it's an interesting non-clinical situation, but the HIE was able to help identify that and help put that person in touch with somebody who could help them. Next slide, please. COVID-19, obviously, this is what we live day in and day out right now, especially as we're having spikes as you're seeing across the country. The HIE today sees about 96% of all COVID-19 testing. We don't see it all because we're not connected to every single site across the state, but we're able to model this data and report this data to our state. So we serve, as I mentioned, as an electronic reporting engine for those organizations that are operating and sharing data with us. So we report that to our public health department, but we're also able to render this data in a way that's useful for our infectious disease folks at our clinical sites, as well as for the contact tracers working in our public health department. All these dashboards, what you're seeing here are the heat maps and some of the graphs that you're seeing about across county, about counts, positive case counts. But as you drill down, this goes right down into patient level detail. And then that patient level detail can then be brought forward and looked up in the HIE clinical record. And that's being used statewide right now to support contact tracing, as I mentioned. It's also we found that looking at our data sets, one of the missing data elements that our public health department was really challenged by was race ethnicity. In the data that they're getting in their laboratory reporting, they weren't getting uniform data. And what was very interesting is that within the HIE, we actually have pretty decent, I wouldn't say it's perfect, but we have pretty decent race ethnicity data. So we've been able to use this to help our public health department and our Department of Health and Human Services identify, where there are disparities related to race, and also heat map that to locations, so they can identify individuals and locations and determine the appropriate policies and processes to engage those individuals and families who may be experiencing race or ethnic issues tied to the pandemic. Next slide. These are just some of our stats. I pulled these stats out literally yesterday for our October stats. So we had about 148,000 unique patients accessed in our clinical portal last month. All-time high, actually, which is great, by about 5,700 clinical users. Much as I'd say about between 1,000 and 1,500 of those are physicians. The rest are mid-levels. We have a 1.4% opt-out rate, and as you can see, we've got lots of data moving. As I mentioned, 446,000 folks that are using our data for analytics and for ACO, and over 1 million alerts sent out last month to our public health department. Next slide. One of the things that I was asked to talk about is sort of the business model. How do we make this work? As I mentioned, we're a nonprofit. We provide these services statewide. And I talked about all the connections that we have and the organizations we work with. The way that works is everybody pays. We have a per member per year model that not only does the clinical community pay, but our Medicaid department pays, our public health department pays. And what we've done, working with my board and working with the stakeholders, is that we target that PMPY to our cost of operation, our base cost of operation. And then as far as our research and development, our innovation, that comes from our ability as a nonprofit to solicit grants and work with philanthropies as well as state and federal funding opportunities. We also have a for-profit subsidiary called Curious Innovations. We built this and actually formed this just over a year ago because we were doing a lot of work with other HIEs around the country, helping do consulting, but also started working on the technology side. We have a small software development team, and so some of the tools that we have to make the HIE operational here in Maine, they're transferable, and we wanted to bring that forward to the rest of the community nationally to help our other fellow HIEs. So we created this subsidiary, and we use whatever profits come from that subsidiary to further support our R&D and bringing forward more tools, and better tools and more unique tools like that in context application, for example, to our state with other partners. So that in context application we developed with another HIE, the Maryland HIE. So we try to find innovative ways to bring new technology to the table and be thoughtful about what we bring forward that actually that allows us to partner and help other HIEs do well. Next slide. So there's a couple of stories I have in here. We'll quickly go over these. Next slide. You know, this is, you know, HIE is, you know, the numbers speak for themselves in some ways, but really it's all about the patient care. Dr. Mark talked about a patient. In this is actually a patient from a couple of weeks ago at Health Infonet who was visiting a new mental health case manager, a child. And he was having a number of mental health behavioral issues that many of the behavioral health providers that he was seeing were struggling with and weren't finding a resolution for. And they were able to use the HIE to find out that over time this child has had multiple ear infections, and as a result, the child received ear tubes, and that addressed some of those issues. I mean, and it's interesting. You'd think, well, that information would naturally be available. Well, it wasn't available without the HIE and the behavioral health EHR. And that's it's a basic example of why we should be doing this. I've said, and I'll say to you all, I don't think the Health Infonet should have to be here, but we are disruptively innovating in the sense that, you know, we in the health technology field think that this is already happening. Many of the patients that are being seen across our state think that this is already happening, but it's not. It's not happening within our EHRs for a number of reasons, which you're all greatly aware of. But it's these things that really do make a difference. Next slide. And these are some other examples from a couple of behavioral health practices and an occupational practice that talk about sort of where, you know, the value of the health information exchange from being able to capture information in a timely way, going from 1 to 2 weeks to find information on a patient to instantly is really meaningful. And then as you know, when the HIE is being used, as I mentioned, we have a big focus on behavioral health right now. You know, we've always separated the head from the body in healthcare, and it's been true in the state of Maine. And bringing forward the health information exchange to behavioral health practices, you know, it's been really enlightening for us and my team. I have a licensed social worker that does clinical education around the state, working at the health information exchange. And the reality is that a lot of these behavioral health practice exchanges, their data has been completely separate from the care of the patient. And you know, besides these stories, you know, we had one a patient, interestingly enough, where the authorities contacted our community community behavioral health center looking for a patient, and because this patient was on parole and they hadn't showed up for parole, and they were about to issue an arrest warrant. Well, that behavioral health practitioner looked up in the HIE and found out that that patient was an inpatient at one of our large hospitals, and that's why they didn't show up for their parole visit. So very interesting different use cases that come out of just making information available when otherwise it wasn't. So I applaud Big Sky Healthcare Connect for putting the thought that you have, as you saw the services I just talked about, are many of the services that you're bringing about right now as you're implementing these core services, and we look forward to those efforts. And I think, you know, you've got a lot of examples of where this can be successful. And I think, you know, right now, given the world we live in, the federal rules coming down the pike that Jason talked about, the work that's happening in regard to the ACOs and accountable care. These are all prime examples of why an HIE is needed, and then it's the patient story, and that Dr. Mark brought forward. These are real, and this is why we need more health information exchanges around the country. So I'll stop there, and we'll take questions at the end.
Thank you, Sean, and thank you for being a leader in this space as well. Really appreciate that. I think you gave us an extraordinary view of what a mature HIE looks like, and also a reminder that a mature HIE is one that continually evolves and has the nimbleness to move in directions of new clinical use cases like COVID, for example, to really take data and serve up that data so action can happen. And we're headed that direction, and we're glad we can follow in the footsteps of individuals like you. Next, we're going to turn to Dr. Randy Thompson of Billings Clinic.
Good morning. it's always a tough act to follow such a distinguished panel. And I really want to thank our panel members with Farron and Sean sharing their experience with mature HIEs and the benefit, with Jason talking about his skepticism and his journey to acceptance. And then really that great example by Dr. Mark, and you can take his experience and multiply that by every practice and hospital and facility in our state, and we have that same experience leading to delayed care and dissatisfied patients and providers. So thank you, panel members. I'd just like to start out just by asking a question. Why have people been so persistent in working on making a statewide HIE for Montanans a reality? Because this has been going on really since 2006. The answer, of course, is it's the right thing to do for Montanans and for the people who are visiting our state. But I really want to thank everyone who's been persistent in trying to make this concept a reality, including Jean, who's really led the charge for many, many, many years in her current role as CAO of Big Sky Care Connect, all the board members, all the people who are on committees, everyone who's been involved. There are literally thousands of volunteer hours that have gone into making this a reality. And I really want to call out Governor Bullock for pushing us to get to this place. So if you have a chance to interact with Dr. Bullock on his last days here, please thank him, because I think this will be a huge legacy item for him. And I think our new governor, who's a technology supporter, will be really supportive of the fact that we're using technology to improve the health of our Montanans. Just really brief history. This has been going on since at least 2006, when the community hospital of Anaconda first got their HRSA grants to start looking at some of these concepts. We went through a failed HIE rollout with HealthShare in Montana. We had a Billings Clinic pilot program, which started in 2016 and ended in 2019 when Big Sky Care Connect was stood up. And now, finally, third time's a charm, Big Sky Care Connect, and we're really close to going live. When you look at really the value proposition, it's in multiple titles. So Big Sky Care Connect, the last two words, Care Connect. This allows us to connect our care. The conference theme, Care Connections, again, connecting care anytime, anywhere, by anybody, privately and securely. So those are really key words. Why is this the right thing to do? Because it allows anyone who's taking care of a patient access immediately to their data, including things like their past medical history, surgeries, medical problems, medications, allergies, lab and radiology test results. So really, this is patient-centric. It's the patient's data. It's not the healthcare institution's data. It's the patient's data. And that data should follow that patient no matter where they go. So anybody who needs to try to improve the health and wellness of a patient needs access to that data and not have it held hostage in some system. So this HIE will really help that concept become a reality. So at Billings Clinic, we have really understood this concept, and we've spent a lot of money and time and effort in creating our own HIE with our Billings Clinic facility and our dozen affiliates who are all in our shared medical record domain. And we have that capability to share data amongst our facilities, but if our patients are seen outside of our network, we have no access to that data. And as an emergency physician, I have better access to a patient's data if they're seen in one of our facilities several hundred miles away than I do from a facility I can look out the window and see. Or I could walk a couple of blocks down to Riverstone and talk to them there. So that is a problem for our patients. And this will help us to resolve problems like that. An unconscious patient who shows up, they really can't provide us any data about what medications they might be on, what kind of allergies they have, the fact that they may have just had a CT scan of their head or their abdomen at another facility, and I have no access to that information. Where this has really become apparent recently is really with COVID. It would have been extremely beneficial to have our HIE up in place during this COVID pandemic, because there is no way to share test results among facilities easily. And so we have access to the tests that we perform in our institution, but if it's performed somewhere else, we don't have access to that data. And just having access to that data would have been extremely beneficial during this COVID pandemic. The fact that Big Sky Care Connect is really working to establish connections with the labs, including the state lab and Quest and LabCorp, is really going to be a big help to the care we can deliver. So as my role, and I don't think I talked about this, so I'm an emergency physician by training. I'm our system's current chief health analytics officer at the Billings Clinic. And then I've been involved with the HIE since 2016, currently a board member and on several committees. As a chief health analytics officer, I really understand the need for access to a holistic picture of our patient. Data, wherever it's generated, should be available for us to consider to improve their health and wellness. Things like screening for cancer, following up on screening results, preventing disease, coordinating care. And that's a really important piece of this, coordinating care and awareness of the patient across the whole spectrum of patient care, of a patient's journey. When they have a problem, they get sick, they're at home, they go to their primary care provider's office, they're sent to the local critical access hospital, they're then transferred to a tertiary care facility, then they go to a post-acute care facility, back home with home health, and back to the primary care office. That whole flow of data needs to be available to every single step in that journey. And this will help us only, though, if we have broad participation. So my plea to you is to make sure to encourage your local practices and healthcare organizations to join the HIE, so we can really make this concept into a reality. Because without broad participation, we won't have access to all of that data. So I think that's all I wanted to say. Thank you.
Well, thank you very much, Dr. Thompson. Dr. Thompson and I were actually on a call yesterday, and you know, it was a new term for both of us, and I think it was information mule. And we were talking about really how things happen now for our patients, and they really are our information mules. They have to carry their records from facility to facility in order to get the care and make that complete medical record available to the provider that they're about to see. And this changes all that up, and that's a good thing for our patients. With that, we want to turn to the chat. So please, if you have a question, please access that chat box and take advantage to answer or to ask one of our panelists a question. And while you're thinking of that question to pose them, I'm going to pose one my own, because it's one that we hear about and Sean talked about, you know, the importance of having social determinants of health. And we know here in Montana the critical importance of understanding and getting connected into that as well. And population health is certainly a buzzword. And I think, Jason, early in our conversations when you were part of that, you talked about the importance and what your facility was doing to look at population health and what you wanted to do in your terms of population health. So can you speak about what the HIE means in terms of really moving that objective forward?
Yeah, I mean, I think it was well demonstrated by both Farron and Sean as to, you know, what we aspire to get to with data, and be able to begin to look at analytics across the population and understand what's driving disease and disease process, and then what we can do about it, right? Well, not just knowing what it is, but how can we make it actionable? And we really don't have those tools today across the state. We might have them within our own healthcare system, but anything that happens outside of our own healthcare system is a mystery. You might get it in some late Medicare claims data, you know, many months later, but not something that's actionable at the time. And I think they did a great job of demonstrating how that data can be used going forward, whether within an ACO, whether within a payer population, or just our own employees. I mean, we have 4,000 employees. If we could just make that more actionable, that would be great.
And Dr. Mark, I'd like to hear your thoughts on that too. You work in a facility that really has and serves an underserved population in Montana. And we know in Montana that our Native Americans, and we had some health disparities. So how do you see the HIE working to help level that field for us?
Yeah, I would agree with Jason's point that the view of the mature HIEs that Sean and Farron shared with us really do provide a pretty aspirational and inspirational example for the current reality in frontier Montana. So often, what the task of improving health outcomes at both individual and community levels is much more about connecting these folks to resources within the community, and the ability to understand and have a more accurate real-time data about what individual and the sort of the community level data that Sean showed us those maps of. That's powerful in terms of creating sort of real-time, meaningful, and effective interventions that can ultimately through time yield some change. So I think in terms of providing just the accurate roadmap about how to invest in we all have very limited resources, and so how to wisely prioritize our investments can be helped by this tool, simply by the roadmap that the accurate and timely data will provide for us.
And Sean, you mentioned that public health was an important partner. We are blessed in regards to having, as Dr. Thompson indicated, the support of the governor, and Governor Bullock's really helped and do a call out particularly to the Medicaid shop, and Marie Matthews, Erica, and the director, Sheila Hogan, is sharing the vision as to what this can be. And so we got a close partnership with Medicaid. Public health is a little bit overwhelmed at the point and with the COVID pieces, but they also are very much an important partner and working with us as well. Share with us about the partnership there and how you formed that and the results of that partnership in terms of really addressing some of these social determinants of health issues.
Yeah, the partnership with public health has been something that's been part of our lifeblood at Health InfoNet since we were founded. It's actually, public health is named in our bylaws and as a specific role of the HIE in public and population health. And as I showed you, we started with standard reporting, electronic laboratory reporting, syndromic surveillance, immunization registry. Those are the standard pieces that we started working with, a decade ago. But now, as we've grown in that relationship, obviously we've become it's all about trust, but we've become a trusted partner to them in a sense where they come to us and ask questions about the data. So whether it's the COVID piece, we weren't connected to the state health and environmental laboratory before COVID, but we were able to very quickly get an executive order signed by our governor, get that laboratory connection in place so that we could support the public health agency in that case, getting the COVID-19 laboratory results out to the provider community. Because what was happening was there's a mandate in our state to push the electronic laboratory results to the public health department, but not the same mandate going back to the provider community. And because our laboratory, they're the confirmation laboratory, the primary confirmation laboratory for laboratory tests, there was a very large gap in the data that our provider community was seeing. So there was a real interest in leveraging the investments they made to push that forward. On the social determinant side, this is evolving, and this is a really challenging space. We started actually working with not only our public health department, but our Medicaid program, because they run the largest transportation program for healthcare in our state. And transportation, as I mentioned in my example during the presentation, is so important, especially in our rural community, getting a person to and from their health visit, to the laboratory, to the grocery store to pick up the milk that they have to take with their medications that they picked up. And so having that information in the health information exchange has not only helped coordinate services, but also because of the relationship the HIE has as a convener, bringing people around the table to talk about what's important here. And now actually we're in the process. We work with a number of pilot sites around our communities around aging. I mentioned that we've got this program for long-term care in our state. Well, we have area agencies on aging that are providing services for persons, for the aged individuals in our community. Meals on Wheels, other types of services, financial services, but also additional information that could be useful to the HIE itself. And so we're partnering with them and a local philanthropy, our Blue Cross Blue Shield Foundation, our public health department, our Medicaid program, to try to integrate data across those two pieces, so that the social services side of the services that these people are getting in the long-term care and long-term services in our community are integrated. And there's details here. Some data is HIPAA, some data is not, but the HIE can be the facilitator, and that's where we find ourselves spending a lot of time in having those conversations, helping educate about what data means. What's interesting, it was brought up earlier, there aren't a lot of resources here, but we have an infrastructure, and our infrastructure is patient-centric, and that to me is the real advantage of an HIE. We see a patient as a person, no matter who their provider is, who their payer is, who their social services agency is. And so we can become that data hub and manage those interactions and manage the appropriateness of data sharing across different stakeholders, including social services.
Thank you, Sean. And I'm going to ask you to look at that chat room because you've got a question there, and we'll come back to you on that, Sean. But I'm going to go to Dr. Thompson and just kind of say, hey, you're from a very vibrant healthcare community over there in Billings, and we're talking about the kind of partnerships that are happening at the state level. And when you hear about that and you think about the different partnerships that are happening right there in Billings, what does this health information exchange mean to the work that you're doing? And kind of building on the comments that you said, is that you can look outside your window and see another large provider and walk down the street and yet see another main provider in that town.
Yeah, so I think the key word there is partnership. From the very beginning, this hasn't been a competition even between organizations that are very competitive. They've all wanted to come together to create this system, this exchange of information, because it's the right thing to do. And we need to translate that across our whole state, because it doesn't do us any good to just have the data from the Billings area about a patient. If one of our patients travels to the western side of the state and gets hurt in Missoula or up in Helena, and there's no access to the information, or they have a stroke or a heart attack, they need that information as well. So that same spirit of cooperation and a belief in the need to have access to a patient's data and have it follow them wherever they go. I mean, we need broad participation, and we don't need competition. We need teamwork and participation. So I don't know if I answered your question.
Nope, that's great. And Farron, I want you to kind of build upon that and just have a question for you in regards to, we're talking about the benefit, and we are at the golden circle here about talking about improving patient outcomes. But there also is a benefit to the provider side. And I'd like to hear your insight in regards to what you have seen with your HIE in regards to really providing administrative relief to our providers who are now facing burnout and has been experiencing burnout in increasing levels due to increasing administrative regulations.
Sure. I think this has been touched on a little bit earlier, but, I think you can equate clicks and other administrative headaches to physician burnout. And, certainly some of those headaches is, if they're looking for patient records and whether they have to log into multiple different portals. Portal is becoming a four-letter word in healthcare as well, because there's so many portals out there. But whether they're logging into a portal to look for clinical data, or whether they're doing the fax chasing or phone calls or whatever, it's all just frustrating for physicians. So, if you can reduce all that, and with a few clicks, you can get to all that information at your fingertips and trust it and rely on it, it's going to make their lives a lot easier. And, every part of the country is experiencing physician burnout, and, anything you can do we're not going to eliminate clicks, right? But if you can reduce them, make them smarter clicks, make those clicks juicier. If you're implementing single sign-on technology, that's great. The sophistication in healthcare around managing passwords is pretty horrible still, but single sign-on really helps make that better. And the more systems you can put under your single sign-on and the more you can make them accessible, if you can integrate your HIE data in context, like Sean was showing they've done with Epic, I mean, you untap vast amounts of data and just make lives easier. Over time, as you do it incrementally, you probably don't notice it, but it just makes that administrative burden and the frustration factor so much better.
Well, thank you, Farron. And I tell you, clicks matter. So I wish we could be the single click organization, and we're certainly going to try to be a less of a click by bringing in and doing that single sign on and also doing direct query information. And minutes matter as well. So I can imagine the ER physicians and other physicians that have 3 or 4 screens open waiting for information so that they can move forward to treat their patients. And making that be more timely is good for all of us. Well, it's 12 noon and this time has flown by. Thank you so much for being a terrific panel. What I'd like to do now is just give you each just a real quick closing moment to say, gosh, if you were going to talk to our audience directly and sit across the table from them, what is the one thing that you would like them to keep in mind based on the conversation that we had today? And we'll go ahead and start with Dr. Mark. Oh, we have you on mute, Dr. Mark.
Oh, I would just reiterate what I think was mentioned earlier by Randy, which is this only gets better the more of us that participate. So please join. It'll be better for all of us.
And Sean.
I'd say it's a great time to be starting an HIE. The technology is way better than when we started, and we're dealing with a lot of legacy. So building off of it's about the relationships, and the more partners, the better the data. But the technology is at a point now where it can truly integrate into workflow, where this wasn't available to us even 5 years ago. So that's really exciting, and so I think it's a very exciting time for Montana and Big Sky Care Connect.
Thanks, Jason.
So for years, I've said you can go to any country in the world, almost any country, and put your ATM card in an ATM and take out the currency of that country. And to Dr. Thompson's point, I can see the clinic across the street and we still fax them lab results. This gives me great hope that we'll be able to move to what the banking industry has been able to do. But Dr. Mark's right. Everybody's got to participate to make it work as well as it can. So thanks for having us today, and it's exciting.
Farron.
I guess I'll just wrap up with focusing on your adoption planning and setting your expectations for adoption really well. Most HIEs in the country that failed didn't fail because they had poor technology or lacked data. In fact, some of them were probably as robust as Maine and what we have combined in terms of the data, but they couldn't get anybody to use it. And so you're going to have fine technology and tremendous amounts of data. If you want this to be successful, really think through and engage your clinicians like you have on this panel, and really think through what does adoption mean. And in each of your different systems that are out there that are participating, I'd encourage you to think about how you can incent your physicians and their staff to get on board and use the technology. It's not one of those, if you build it, they will come, in my experience. Physicians are very tough to adopt new technologies. It's if you force them to use it and then they will come once they see the value of it. So really think carefully about how you get your adoption plan around this.
Super. And Dr. Thompson.
So I'm just going to reiterate, we can't take care of you if we don't know about you. So we need both broad participation by organizations across the state, but also we need broad participation by our patients. And so please know that we have your back. We are safeguarding your data. We have privacy and security of your data as a paramount concern for us. We're going to do all the things that we can to protect your data, but we can't take the best care of you unless we know about you. So please don't opt out.
Well, again, my heartfelt thanks for all of you for joining us as panel members and really showing that the journey we're taking is well worth it. And the results for our patients are just over those mountains that are behind all of you in the panel here. So, and thank you for our participants and our attendees. And, you know, it's through you that this will actually be a success. Your voice matters. And we want to hear from you. So please engage with Big Sky Care Connect and continue to have that conversation, build awareness about the HIE, and as others indicated, join and be part of that solution for that better hope and that better care down the road. And with that, we're going to head off to give you a lunch break. I believe that's 60 minutes, and then we'll be back for another round of panels. Thank you much.
Thanks all.